Hi everyone, welcome to episode 3 of our COVID-19 listed webinar. My name is TJ, I'm one of the chest registrars.
I'm Joe, I'm also one of the chest registrars.
So today we're actually going to talk through CPAP and explain a little bit about how the machine works, what it actually looks like as well, the reasons why we're using it in our fight against COVID-19. We've been lucky to have Emma Medic, who's one of our ACT nurses, go explain things, and we'll come on to some videos that she's kindly done for us. So, as I said, we'll just quickly go through what it is, when we're using it, and how it's set up. We do have some videos later on just to show you how that is, but Joe's going to go through some theory as to why we're actually using CPAP in the first place. There is some really helpful guidance from the BTS NHS England showing the reasons why we're using CPAP versus high flow oxygen, exactly the settings we need to start through. But as I said, through this episode, we'll hopefully summarize all that for you so it makes it a bit simpler when you're on the ward. We recorded this episode on Thursday, the 9th of April, 2020. So as far as we're aware at the moment, this is all up to date. If there are any new versions that get released in terms of CPAP Optiflow in the next few days or weeks, we will update you with that.
Okay, so CPAP is continuous positive airway pressure. To understand this, we just want to go through a little bit of basic respiratory physiology. Please don't switch off at this point. We're going to try and keep things simple so that everyone's in the same wavelength before we go on to CPAP itself. So going back to medical school physiology, alveoli are like balloons. They're little air sacs at the end of the bronchi. So they are like balloons in two important respects. When they're small, they're harder to blow up and also at higher risk of collapse. You can really visualize that. You're trying to blow up a balloon. If it's small, that's the hardest bit to inflate, and then it can just collapse down on itself. We prevent alveoli in normal physiology from collapsing by two mechanisms. Firstly, when we breathe out at the end of expiration, our upper airways close and trap some of the air in our chest. So there's relatively greater pressure in our chest compared to the outside air. And that provides a bit of natural positive end expiratory pressure, which is around 3 or 5 centimeters of water. And again, that just helps to hold open the balloons inside the chest. The second thing is surfactant, which is produced within the alveoli and help by changing the surface pressure to keep the alveoli inflated. However, the production of surfactant is interrupted when the lungs are infected or inflamed, such as in COVID-19. So the air sacs are more likely to collapse down on themselves. If they do collapse, then gas exchange can't occur as oxygen is not getting into the bloodstream because it's not getting into the alveoli. So there might be normal blood flow around the lungs, but they're not being oxygenated adequately. And this gives rise to the concept of VQ or ventilation perfusion mismatch. So with that in mind, what does CPAP do and how does it help here? So CPAP effectively blows in extra air throughout the respiratory cycle through inspiration and expiration to help hold open the alveoli. So this effect also helps to open up the upper airways, which is why we use it for conditions such as obstructive sleep apnea. But by holding open the alveoli at the lower respiratory tract, we improve the functional residual capacity, which you can see on this graph is this area here. So we get more oxygen in, reduce the mismatch between the perfusion and ventilation, and overall increase the oxygenation of the blood and then end organs. In addition to that, CPAP also helps to reduce the work of breathing because we're holding open those little balloons. They're starting from a better position to inflate. So it reduces the amount of strain on our respiratory muscles, and patients are less likely to tire. There are also added cardiovascular benefits. It reduces the preload and afterload on the heart, and that's partly why it's beneficial in acute settings for patients who have pulmonary edema from congestive cardiac failure.
So it's really important to know why we're giving CPAP to certain patients, because ultimately we have to think about what are we achieving when we put CPAP on a patient. Now, at the moment, quite a few of you have probably had the experience of having a patient on the ward who has slowly been getting much more unwell in viewpoint of their oxygen saturations falling. Then their oxygen in the inspired oxygen has been going up and up and up, and suddenly you might find that this patient's on 50-meter non-rebreathe mask, and they're working quite hard. Their rest rate going about 30-35 breaths a minute. Well, is this the point now that we think that we can use CPAP, and as Joya said, to help with their work of breathing? So that word PEEP is something that you've probably heard both of us and a lot of the respiratory team talk about in the last couple of weeks, because that PEEP is exactly what we're trying to achieve, or trying to use that CPAP delivers to be able to help these patients. So it will correct their hypoxemia by recruiting alveolar, and again, it reduces their work of breathing. What we've found in certain studies from China, and actually from Italy as well, is that early intervention. So if you've got a patient that you know that is going to head that way because they are just getting more and more tired, or they're working harder and harder, then early intervention CPAP might actually delay them having to be intubated and going off to CCU, or actually might avoid it altogether. They might be able to do quite well in CPAP, and then we might be able to help them that way. This might be their ceiling of care. So if already we've identified this patient that ITU may not be able to help necessarily with ventilation, but they could still be for CPAP, then this is why it's really important, because this might be their last chance. If their oxygen requirements going up and up and up and their respiratory rates climbing, this might be their last chance to help them. So it's really important that you assess each patient case by case, because not everyone is suitable for CPAP. So is it safe to use CPAP for each patient? Yes. So essentially there's certain things that most of you should be aware of to check, but again, we'll just go through them here. So always check the chest x-ray. You don't want to be starting CPAP or any kind of NIV on someone that's got a small risk of a pneumothorax, or even has a pneumothorax, because of course that's going to just make things infinitely worse. So always check the chest x-ray before you even consider starting CPAP or NIV. Whilst most patients will probably have good skin, or at least they won't have any ulcers, be aware that when these masks go on their face, if they're on it for a long period of time, it can cause ulceration around the nasal bridge, can even cause sort of some pressure issues around their face. It's not a comfortable mask, and the videos that are coming up will show you exactly how it looks. It can leak upwards, so if that mask isn't fitted around the face correctly and air leaks upwards, it can dry the eyes out. It can actually cause some real issues with some patients. And of course, being as they're now being nursed in side rooms, because we have to wear PPE and be cautious of the aerosol generating issue that it causes, then you might not actually notice this until it's a bit too late, or in fact patients might not be aware of it themselves. And it can distend the stomach, so you might notice that some of these patients who are currently on CPAP, you might see that their abdomen is a little bit distended, and we have to think about whether actually that's actually making things much worse, and an NG tube might be the correct thing to use at that point. Of course, if they're on CPAP quite a lot of the time, then NG tube again may not be the right thing, because of course that will stop the mask from fitting around the face. So these are the things we have to think about when we're starting someone on CPAP. Most of you have asked question of, is it safe for us? It is safe for us. So we know that as per the BTS guidance and NHS guidance, that CPAP, NIV, all these forms of ventilation are aerosol generating. There's lots of studies shown in terms of how much they aerosolize the virus, but it's safe to say that, well, it's safe to say that within these rooms, you should be wearing the formal FFP3 mask. You should be wearing a visor. You should be wearing a full gown and gloves when you go into these rooms. But as long as it's got a good seal and you're at a good distance away from the patient, then you are at a minimal risk.
So CPAP sounds great, and you think, well, why don't we use it for every patient? So there are some situations when we shouldn't be using it. So there's obvious absolute contraindications. Pneumothorax that TJ mentioned, but particularly any issues with the face. This is unlikely to apply to any of our COVID patients, but it's something to bear in mind if they have obvious trauma or burns to the face. then putting a tight fitting mask is not going to be possible or safe. We are using CPAP at the moment on a sort of a medical HCU setting just for single organ failure, so respiratory failure. For patients with other organ failure, for example, if there's association with sepsis, so AKI or liver injury, then critical care is likely to be the more appropriate place for the patient to be looked after. Similar principle to how we use the respiratory support unit normally. So there's the issue with hypotension. So CPAP does slightly reduce the blood pressure, but this is pretty modest, only by about 2 or 3 millimeters of mercury, both systolic and diastolic pressure. So it's unlikely to make a significant difference, but if you have a patient who is already borderline hypotensive, then starting CPAP might be a bit of a consideration there. So patients may not tolerate this. They may be too agitated either up front to start it, or once the mask goes on, they may become too agitated. Or it might be that having to describe to a patient what it's like, they say, no, I don't want to have that. So the sensation that I would describe to a patient is it feels like sticking your head out of a car window at high speed and trying to breathe. It's that sort of force of air into the mouth. Most patients are fine with that, but there may be objections, in which case that early discussion and explanation of what it is really important. It's debatable how much CPAP will add in bacterial pneumonia because of the airways are already completely bunged up with thick mucus and so on. There's little further alveolar recruitment. But what we're seeing with COVID-19, this isn't obviously a bacterial pneumonia, and there's less mucus production within the airways. So it's likely to be a little bit more effective, but something to bear in mind. As with a lot of these things, though, it's really difficult in advance to predict which patients will A, tolerate this, and B, who will actually have benefit from CPAP. So we always refer to this as a trial. For those who tolerate it and are improving or stable, great. And for those patients who aren't, then we need to think about a plan B, and we'll come on to that.
So let's just summarize what we've said so far. You've got a patient who's deteriorating on the ward who you think could be suitable for CPAP. First check on their TEP form, is this patient actually for non-invasive? If we've already been marked as ward-based care only, but without this, then unfortunately high flow oxygen in terms of 15 litres non-rebreathe is the most we can go for these patients, and we'll have to support them that way. If they are for CPAP, then check the recent chest x-ray. If you don't have a more recent one, or if they've been in the ward for a while, then you might want to get an up-to-date one. Ensure that there's no obvious pneumothorax that's now causing their breathlessness. If they've come in very recently and they've had an ABG already when they were on sort of 10 to 12 litres, even more, and essentially they've just got a little bit worse than that and now working harder, don't think we need to repeat an ABG at that point just because they've got a little bit worse. We kind of already know that they are, hypoxic type 1 respiratory failure. It's only really useful to know whether we can actually titrate the oxygen in any other way. For example, certain patients might actually be on 10 or 12 litres of oxygen when they don't need to be. So if we think that they're on that that we don't think they need to be on that, and we have an ABG and their PO2 is actually relatively reasonable, it just gives us an idea as to what we're playing with. So as I said, if they come in very recently, you already know they're type 1 and they've got worse since then, just think, do they really need a repeat one? Because we know where this is going. Explain CPAP to the patient. I think that's just really key, because we are obviously seeing these patients through our new style wards where we've got these doors, and they're now protected with the doors, and we're sort of watching them from our nurse's station. But if we see a patient that's in distress and we think they could be for CPAP, please go and explain to them what we think we would like to do for them. There are certain patients that maybe even had it before in the past, or even own one of their machines because they're a known sleep apnea patient. So it will give you an idea as to whether we can actually go forward with this or not, because certain patients will not tolerate this, and it'd be a shame to move a patient all the way from the ward down to the respiratory unit to have a go within the first 10 seconds they just say, no, I don't want this. it's something that we could have avoided. If we've got someone that we think can tolerate CPAP, they agree to it, and we want to just get cracking with that, contact AMU Green, contact the respiratory reg or the respiratory consultant who's around in the daytime. Of course, if this is night, contact the medical registrar, and if we need to, we can call, the medical registrars can call the respiratory consultants on the phone to arrange an urgent transfer. We have currently got 4 beds in RSU. We are hoping to get more, depending on our ventilators. At the same time, we have to be quite cautious. As much as we'd love to put everyone on CPAP, not everyone's going to be suited for it. So we do have to do a little bit of moving around just to get these patients accommodated. To transfer these patients quickly on high flow, non-rebreathe mask. Of course, because we are using an aerosol generating procedure, they all need to be in the side room, particularly if we know they're COVID positive. As again, RSU have got this sort of room structure already agreed upon. And of course, just to remind you, if you're going into these rooms, staff needs to be in full PPE. So you've got your mask or your hood, your visors, your full gown, and your gloves. Make sure you do not go into these rooms without wearing all this.
So in terms of the equipment itself, and again, Emma will go through this, you can visualize it in the video in just a moment, but the patient needs a full face mask around here, or just an oronasal mask, and both of those will reduce the aerosol and get a better seal. Again, little technical aspects which Emma will show you in a second, that the masks we're now using are non-vented, again to reduce the aerosol exposure around the room, and the expiratory port is built into the circuit, so the patient breathes out into the tube rather than into the room, and that goes via a filter, which is really important here to protect the staff and the machine. It is possible to damage the machines if the filters aren't used properly, and this puts them out of action and is quite expensive to fix that. Another important point to note here is that if patients come in with their own CPAP machines, so our chronic obstructive sleep apnea patients, for example, you can still use their machine, but all of the tubing and the filters, etc., will need to be changed so that it matches this policy. So the first thing to do with the patient is to invite them to hold the mask to their face, partly to measure it up and so that they can get a feel for what that's going to be like. And then the sequence of actions here is really important and slightly different to how we'd normally do it. So with the mask held to the patient's face with a good seal, then turn on the machine, the ventilator. And similarly, when you want to take the mask off, turn the ventilator off first and then the mask away. What we're trying to prevent is having a mask that's contaminated with the patient's secretions and the ventilator on and just dispersing that around the room. Once the mask is on the face, gently tighten the straps to get a good seal. Try not to over tighten it because it can be quite a lot of pressure and give the patient a bit of a headache. To achieve this, patients with a beard might need shaving with consent. And different mask sizes might need to be tried, particularly for patients who have different shaped jaws. So, important bit here, particularly for doctors who will be prescribing this, is that the pressure we're starting CPAP out, as per the guidelines now, is 10 centimetres of water, which is a little bit higher than what we normally use CPAP at. Although we're saying 10, that's quite a lot of pressure for the patient who's not used to this to start on straight away. So it's worth setting the machine at 5 initially, which again Emma will show you, and then over the course of a few minutes slowly increase that CPAP pressure up to 10. It just gives the patient a chance to adjust to it. And the amount of oxygen is 60% that we're putting through the machine as a starting point, and then titrated from there. So this does need to be prescribed. And there's a special form to do this, which we'll show you. So this is our typical NIV prescription form. Most of this is applicable to NIV and not CPAP, so don't worry about too much of this. But the bit to highlight is here it says CPAP. Ignore the 5 centimetres because what we're aiming for initially is 10 centimetres. and the prescription will look something like this example. So time and date, just ignore the IPAP and the EPAP, which are the NIV settings, and the pressure support. What we want to write is the oxygen concentration, so 60%, and the CPAP pressure of 10 centimeters initially, and sign and date. Sign and print your name. And then later on, for example, if we want to increase the pressure, this first prescription will be crossed out and then a new one written underneath, for example, with 12 centimeters. But again, we'll come on to that. There's also documentation for the nursing staff for care bundles and monitoring of CPAP, but this is the prescription chart.
So this is just a general picture showing you how the machine's set up. So this is one of our NIPI machines. We most likely won't be using these machines to start CPAP. We've got some other machines that Emma will show you. But this is just the standard machine with the tubing, and then you can see the face mask here. So this is not the one that goes around the face, this is just around the bridge of the nose. But this is essentially what it basically looks like once it's all connected up. This is just sort of shows you a bit more of a focus on what the actual tubing and the valve looks like. So this thing is particularly important. If you don't have this, then please don't start any of your patients without this valve. This is particularly important. And again, Emma will show you exactly how to set this up. So without further ado, we're going to play a couple of videos that we've asked Emma to do, and hope you enjoy them.
Hello, hi, my name's Emma, one of the respiratory nurses. I'm just going to be talking through how to use the CPAP machine, the changes that we've been making in regards to the tubing, and I'm going to show you how to fit onto a patient's face. So first of all, this is our Stellar machine. So this machine can be used for both NIV and CPAP, which are two different things. However, the setup is the same. One of the most important things to mention is at the back, you do have a filter. This is now going to be changed with every patient. So all you have to do is take the back off, take the filter off, which is quite easy, and then that's it, and that will be disregarded in a new one in between every COVID patient. Quite easy to put back on and to put this one back on. The other changes to know is that the oxygen's no longer going through the back of the machine, it will be going through the mask. So I'll be able to show you how to do that. So first of all, to turn the machine on, it's just a little switch here. You just flip it. The machine can be used for transfer, so it does have an internal battery, but please make sure you're always plugging your machine on and turning it on, so we can make sure the battery is at 100%. So while we're waiting for the machine to turn on, only takes a few seconds, I'll just show you the changes with the ventilator tubing. So first of all, to set up the machine, you need your normal tubing, which we'll just place on the end here. Okay. So the changes to the machine that currently is on the face mask, it is now a non-vented face mask. So we used to use vented face masks, so when patients exhaled, it would come through the tubes on the face mask here. However, we don't want to be breathing COVID at patients. So in order to help with infection control, we're changing all the face masks. Now, because we're changing all the face masks, we need the patients to be able to exhale. So in order to do that, we now have an exhalation valve. If you're using Drager tubing, which you will know, there is a Drager at the top here, it says, there is an exhalation valve inside the tubing, so you do not need to add one. If you're not using Drager tubing, because there's two types of tubes, you'll need to use this valve. The valve won't fit on the Drager tubing, so you know that you don't need it for this one. It will fit on the other tubing. You definitely need an exhalation valve, otherwise it's unsafe for the patient because they won't be able to breathe out. In order to make it safer for you as well, we're also having the HME filter. This is a bacterial filter that filters out the air. Instead of having it normally here at the machine, it's now being placed above the exhalation valve. The reason for this is when the patient breathes out, it's going to go through the HME filter, clean the air, and then filter out of the exhalation valve and into the atmosphere. We can't say this is 100% going to remove all of the COVID. However, it's good at cleaning, and hopefully it's going to help make it that bit cleaner for you. So this is still an aerosol-driven items. You still need to wear your FFP. So the main changes are the HME filter is now being placed before the face mask, and then we have our exhalation port here. And we're now using non-vented face masks. So this face mask is non-vented, and also this full face mask here as well. Okay. So we're now changing where we place our oxygen, as I said, so it's no longer at the back of the machine, it's now going to be through this port here. So you use your green tubing as normal, and you just connect it to the wall. So unfortunately, it's going to be through litres, so you'll need to work out your percentage with blood gases. So that's the most important things that have been done in regards to the changes. The next thing that I can tell you about is how to pick your face mask. So there's two types of masks for patients. We have the full face mask and a full face mask. To make it confusing, they both do exactly the same thing. However, there's different reasons that you may pick them. They both come in different sizes as well. So if you have a patient that's really anxious and claustrophobic, this face mask will be your choice. The reason why this is easier is because patients can see everything that's happening, whereas when you put this face mask on, their eyes are quite blocked from the vision and they can't always see what they're doing. So this face mask may be a good one to choose. It's also really important to look at your patient's skin. If you think your patient's skin can break down easily or they're at high risk of pressure sores, this will be your best face mask. The reason why is because this one sits on the bridge of the nose and it can cause skin damage. Now, you're more than welcome to use this face mask, and if you find that your patient's skin is breaking down, please swap, because we need to make sure that we're caring for our patients. Another good thing to mention is with this face mask, the eyes are more likely to get very dry because you're having dry, harsh air being thrown at the eyes constantly. So it's really important that we're doing eye care regularly. This can be done up to 4 hourly, and you just need to use gauze and normal saline just to hydrate the eyes. So they're the face masks that you can use. In order to measure for this one, it's really important that you measure from the bridge of the nose down to the mouth. And on every packet for them, there is a measurement at the bottom that shows you how to do this. Okay. That's the most important things in regards to setting the machine up and how you're now going to be using it. So I'm now actually going to use one of my colleagues to show how to put the face mask on. So TJ. Okay, so TJ's going to be helping me so I can show you how to put the face mask on. But firstly, the most important thing is that you have your machine set up and ready to go. So in the past, my background is intensive care nursing, and often I would have my machine ready, put it on. If I needed to readjust it, I would readjust it. I wouldn't often stop the machine before. However, now the crucial things that you need to know is that your machine needs to be ready. You're going to put your face mask on, you're going to tighten it and get a good seal, and then press start. If you need to readjust, you need to stop the machine, readjust the mask, and press start. If you need to take off the machine, you need to stop the machine first and then take off the mask. So it's really important that we reduce the amount of aerosol in the atmosphere if we can. So first of all, what we're going to do is we turn the machine on. So now I'm going to show you how to do your learn circuit. A learn circuit is really important because it enables us to check that the machine is safe. So first of all, you come to this screen and you're going to unlock. You press the middle button and the 2 ticks and you hold down for 3 seconds. It's really good to make sure you only unlock for 5 minutes because you want to make sure the machine is locking again and that it's safe. And that way no one can adjust your settings. So when you come to the home page, you have a ramp, a face mask and a learn circuit. The most important thing to do first is your learn circuit. So your settings your equipment needs to be set up with the face mask and the HME filter, because the learn circuit not only tests if it's safe to use, it also checks for the dead space. So then you know that the ventilation observations that you're getting are just from the patient and it's nothing regarding the ventilation tubing. So all you have to press is start. It's very easy. You just press start and then it does it for you and it will let you know if it's safe. I would also always say if it fails the first time, check all your equipment, make sure that it's all on tightly and it's all on the correct way and try again. If it then fails again, then look to get new equipment and see if anything is faulty. So we'll just wait for that to complete. It only takes a minute or so. You should do this in between every patient and any time you change the ventilator tubing. Okay, so it's come up with a happy face, so it means that it's safe to use and we can now use the ventilator tubing. So the first thing you can do is check your mask type. So you move this spinny thing here, you click on it and it says full face. We should only be using full face. There are settings for paediatric and trachea. However, in an adult setting, we should only be using the full face mask unless a consultant has said otherwise. Okay, so now we're going to go to the settings page. So the settings are just here, the 2 double ticks. Our mode, you can change that by clicking here. It will turn orange and then you can decide which you would like to do. If you want NIV, it is ST mode. If you want CPAP, it is CPAP mode. The Page is quite easy. There's only one setting to change, so it's your CPAP. Patients have been recommended by NHS England that we should be doing a CPAP of 8 to 10. However, I would recommend starting at 5 because we don't want the patients to rip off the mask because they're uncomfortable. It's really important that we're making it as comfortable as we can for them. So if we start at a low peak of 5 and then slowly increase it, they're more likely to get used to it, more likely to be happy with the machine because it can be really uncomfortable. The next setting is advanced settings, which really aren't advanced. So we have our triggers. The trigger is basically letting the machine know when the patient is inspirating and expirating. So it's giving them an idea so they can understand when to put a backup rate in. It's not really needed for CPAP, however, it's still there. So please just set at medium unless a respiratory consultant or registrar say otherwise. The next thing you can also do is the face mask, which we've already set on the front screen, so we don't need to change. I did forget to say, sorry, on the CPAP, this goes up in points. Please don't go up in points. Just go up 5, 6, 7, 8. However, please do not change the settings unless you feel comfortable to or you are trained. Speak to a consultant or a respiratory registrar before. On our next page, we have our alarm settings. A lot of these alarm settings, you may be unaware of what the normal limits should be. Don't worry, we're not expecting you to, but just make sure that all your alarms are on. And if you're concerned that they're not on, speak to one of the nurses who's trained or one of the doctors that's trained to ensure that the limits are set tight. We need to make sure the limits are set in the right manner because we don't want to be going into rooms if we don't need to, but we also want to be going in if the patient needs help or if the machine is not working properly. So we can go the whole way down and you have minute volume, respiratory rate, peak pressures, and apnea, and you can pick that yourself. On the last setting page, we have the ability to do the learn circuit. So if it doesn't come up on the front page, you can go through the settings to find it. And we also have ramp up and ramp down. These settings are really important for comfort measures for the patient, especially as we want to keep the mask on at all times while the machine is running. It's really important that we do the ramp up and ramp down for patients if it is appropriate and if they're clinically well enough for this. Normally, as a nurse in respiratory, when I start NIV or CPAP on patients, I would be showing them the mask and letting them feel the air, putting it to their face so they can feel what it's going to be like. However, because of COVID, we're unable to do this, so it's really important. It's really important that we're making it as comfortable as we can for the patients so they're more likely to be able to tolerate it. So by doing the ramp time, if you're doing it up, it means that you're slowly increasing the PEEP so the patients can get used to the new adjusted. Your normal intrinsic PEEP is 2 to 3, so to suddenly go up to a 10 is a massive jump and patients might find that extremely uncomfortable, so they're more likely to pull the mask off. So if you do a ramp up, at least that gives them time to get used to it. Also, if you have patients that are on a PEEP of more than 10, this is actually very high and it can be deemed as a high PEEP. So it's really good to do ramp down as well, because if you're taking a face mask with someone who could be quite dependent on it, their saturations may suddenly just plummet. So it's really important that you do ramp down as well for these patients if appropriate and if you can, because it would just allow their bodies to get used to that PEEP slowing down. The ramp time can be anything from 5 to 20 minutes. So that is your free settings pages and that's your machine setup. The last page I'll show you is here, which is your observations. So this is really important because you're able to get your tidal volume, your minute volume, how much the mask is leaking and your respiratory rate. So it's an important page. And if you're interested, you can look at the waveforms as well. Okay. The last button down here is just an information button. It can be quite handy if you're busy because you can look and you can see when anything has been adjusted or altered. So you can see that I've just done a learn circuit. It will also tell you for any alarms and any changes to the machine. So our machine is now set up. So we will now place the machine on my lovely volunteer. Okay. So I can see TJ's got good skin, so I'm not concerned that his skin's going to break down. He hasn't got fragile skin. However, that doesn't mean his skin won't break down. So it's important that we're doing regular mouth care, eye care, and pressure care. So first of all, I'm going to put the mask over his face. I'm going to place it here. It's really good if you just get a seal of where you're putting the mask and then do it. If it's your first time doing it, I would recommend doing it in 2s because it can be a bit hard when you're not used to doing it. So you're going to put it in both ways here. You're going to tighten. You don't want it to be too tight, but you want it to be tight enough that you're going to get a good seal. So it might be practice. It might be that you start the machine, you can see there's a leak, you stop the machine and you readjust it. A good thing to do, I know it's hard with gloves, but if the machine is leaking, feel around find out where the leak is, so then when you stop the machine, you know where to readjust. Okay, comfortable?
Brilliant. Thank you very much, Emma, for that. So at that point, once the mask is secured on the patient's face, we just need to press start on the machine. For those of you who haven't had the demo session yet, Emma and other colleagues, including Rosa, have been running a fantastic simulation CPAP teaching session over the last few days. So we're now going to look at what happens next after that's been started on the patient. It's really important that they're not just moved to RSU and started on CPAP and left. We need to keep a really close eye on these patients. So they all need to be reviewed within an hour of starting on CPAP. And there's a number of different ways that things might go at this point. So we'll look at the different eventualities. So if the patient is still hypoxic, despite being on the pressure of 10 and the oxygen of 60%, then the pressure can be gradually increased in steps of 2. So 12 initially, and then up to 14 or 15 after that. And likewise, the oxygen can be increased from 60% up to 100%. But at every step, this does mark a continued deterioration in the patient. So ITU should be kept up to date with which way things are going. And as we mentioned before, if you change the settings, do make sure that's reflected on the description. And so the nurses are aware of what settings are. If the patient is still deteriorating or they're just not tolerating the mask, then again, we need to urgently rediscuss with the critical care team for consideration of intubation as per the TEP form. It may be that the patient is anxious or distressed, and we can help to calm that down so that they tolerate the CPAP better. So simple things like making sure that the mask isn't overly tight, it's fitting well, simple things like that will help. But we can also give low doses of medication. So for example, benzodiazepines or small dose of lorazepam can help with anxiety. There's a specific drug interaction to flag up here that it interacts with lopinavir and ritonavir, which is one of the recovery trial drugs. And through the cytochrome P450 pathway, the effective dose of benzodiazepine is largely increased. So just be cautious of that. Or we can think about giving a low dose opiate, particularly if the patient is really hyperventilating. This will help to reduce the patient's own sensation of breathlessness. It reduces their rapid respiratory rate and tidal volume, and helps to reduce a phenomenon called patient-induced lung injury. These are low doses, normally less than we'd use at analgesic doses, and it can be quite effective. Then on the other side of the spectrum, the patient's actually doing really well. They can start to have breaks off the CPAP and put back onto the non-rebreathe mask that they probably came from. And this allows them to be able to eat and drink, to have better conversations with medical staff and with their family over the phone. And there's a good chance to give them medications, tablets or nebulizers. And then longer term, once the oxygen is less than 40%, we can start to step them down off the CPAP. And that's a really good sign and marks an improvement.
So CPAP isn't the only option, but the next two are just sort of brief explanations of what other things we can use. But obviously these are things that we need to discuss with the medical reg or the respiratory team. So BiPAP, as you are mostly all aware, it's about offering non-invasive ventilation, but mainly to hypercapnic patients. For those patients, you've done a gas on, they are acidotic, they've got a raised PCO2, then this is the cohort of patients that BiPAP is more suitable for. So as I said, discuss with the respiratory team in and out of hours whether these patients can be moved to RSU and AMU Green to have a trial of NIV there, or whether they do need to go to CCU as well at that point. As Joe had said earlier, it's really important to remember that what we're talking about is respiratory failure if they've got any type of other organ dysfunction, whether they're hypotensive, their renal functions off, then actually these patients should be first discussed with CCU before before you discuss it with the respiratory team, because we can't offer that anything but respiratory support on those units. So as per guidelines, these are the sort of the initial starting pressures that we tend to start in IV4. So in our guidelines, they suggest an EPAP of 5 and an IPAP of 12 to 14. And these are gradually titrated upwards until the patient's comfortable and we're getting some response from that. At this point, if you know you've got a hypercapnic patient, we should be targeting our oxygen saturations to 88 to 92%. Remember that not all COPD patients should have that target saturation. Again, it depends upon how severe things are for them and what their initial blood gas shows. But again, if you're not sure, discuss with the respiratory team. And again, you just need to monitor how they respond to the NIV as they would do with CPAP. Optiflow is something that many of you have brought up this week. I know there's a little bit of confusion as to what high flow nasal oxygen and Optiflow mean. Well, essentially it's the same things. It depends on the actual machines that we use, and certain people describe it by the trade name of what the actual machine is called. Optiflow is probably the one that's more commonly used in terms of phrase. And essentially, we are giving high amounts of oxygen at a high flow. So similarly, like CPAP, it is mainly for type 1 respiratory failure. But the issues that we're having is that studies show it's not as efficient for COVID-19 cohort patients. Optiflow tends to give around a peak of around about maybe 2 to 3 centimeters compared to obviously what CPAP can offer. So it's not been shown to be that good for the COVID-19 patients. The things about it that we do like are that it is actually much more well tolerated than CPAP machines. So compared to the full face mask that you have for CPAP, with Optiflow, it's a nasal prong sort of device that fits around the head. And actually patients are much more comfortable with it. They can talk, and importantly, they can eat and drink. And it is less nurse intensive. So obviously they don't have to deal with the problems with the mask leaking or the machine alarming because of certain issues. Once it's set, you can monitor what kind of oxygen concentration or FiO2 the patient's on, and actually just start to wean things down depending on how they are and what their respirator's doing. But as we said, at first point, we should be trying CPAP. And if you are thinking of switching to Optiflow as something for a patient overnight, discuss it with the respiratory team. They'll be able to advise you on whether it's actually a useful thing to do.
So if you want to take this one step further and get a bit more information on ITU level ventilation, this is a really good webinar produced last week by the European Society of Intensive Care Medicine. You can either copy or click on this link or just search on YouTube for how to ventilate in COVID-19. It gives a really good latest thoughts on what the pathology in COVID-19 is and mechanisms in ITU to deal with that. So have a look, and it's something we might come back to with the ITU team for a future episode. So
that concludes our third episode on CPAP. I hope that's been useful for you, and hopefully it's answered a number of your questions with regards to who, in terms of patients, are appropriate candidates for CPAP, how to set it up, and the issues with it. As always, please send your feedback, any questions or any suggestions you might have to us at this email address, so that we can plan future sessions and of course answer any questions you may have.
And as always, thank you very much, particularly to this episode, to Emma Medic, for those fantastic videos on demonstrating how to set up CPAP. Plus Dr. Chong and Dr. Locke from the respiratory department, Michael Chilvers, medical director, and Suresh, the divisional chair of medicine, and the postgrad and comms teams for their support and distribution of the webinar. So thank you all very much for watching. Please do get in touch with any feedback, questions, suggestions for future episodes, and take care.
Thank you.